So I was asked by Jeremy, by Dr. Archer, to come and speak with you guys today about gender-affirming healthcare. As he said, this is one of the things that I do pretty frequently in my job, although I do wear many hats. I was going to just tell y'all a little bit about myself first. So I'm Kristen Dayton. I am, other than all of these things, I'm also a mother of 2 young children, and I've been in Gainesville for a long time. So we came in 2012, but I also was here for undergrad. So I've been here I think most of my life at this point. And I am a medical doctor. I did most of my training at UF except my medical school at Wake Forest in North Carolina. I trained in pediatric endocrinology here. So I take care of children with a wide variety of hormonal issues. And during my training, I had the wonderful experience of training with Dr. Janet Silverstein, who started our gender program at UF. And all through my fellowship, I trained with her. And then once she retired, I took over as the director of our gender program for youth. And really the way the program started out, so in 2016, we started the program officially, but for a long time, Dr. Silverstein and a few of my other colleagues had been seeing transgender youth in the clinic and realized that we really needed a little bit more formalized way to take care of these children. At that point, we still didn't really even have a good comprehensive national guideline for how to take care of these youth, but it was developing and did come out in 2017. But yeah, so I have been with the clinic since its inception, really. And I also just want to say that I have some goals of what I wanted to talk about today, but I really am used to having very interactive discussions about this. So I'm also happy to meet you guys wherever you're at. And if you have specific questions, just please stop me at any point, raise your hand or speak up. I'd rather answer what y'all need instead of just telling you my agenda. And I also will say I am not, a transgender person or part of the transgender community. So while I'm speaking about care for these patients, there are sometimes things that I might say that are wrong or offensive in some way. And please just feel free to let me know if you find that to be the case. But some of the things I wanted to talk about were just to kind of familiarize everybody with some basic terminology and, some facts about the transgender population in our country. Talk about some of the healthcare issues specific to this population, and then tell you a little bit about the facts of medical transition, because I think there's a lot of fiction out there these days too. So firstly, some terms that I use pretty easily now, but back in the day were pretty difficult for me. When I was first learning them were transgender woman and transgender male or man. So transgender woman is somebody transitioning from male biologic sex, male gender, to female. They identify as a woman. And then a transgender man is somebody who typically was born as a female and now identifying and transitioning to male. And just because someone says that they are a transgender man or a transgender woman doesn't tell you anything about what types of hormonal treatment they've undergone or anything like that. You don't have to have a special treatment to identify as a man or woman. It's just their identity of who they are. Then there's also, I think, even maybe some things that make people more confused or uncomfortable is people that identify as non-binary or gender fluid. And I think that really this is becoming something that is more socially accepted, and then helping people to not feel like they have to put themselves into a box. So generally, this is someone who doesn't identify as a gender binary. So they either don't identify as just male or just female. They might feel that they're somewhere along that spectrum. They may even have differences in how they feel from day to day. And they may sometimes go by he or she pronouns. They may sometimes want to go by they pronouns, depending on how they're feeling and how they identify. I think sometimes people have difficulty with using the they pronoun in the English language to refer to one person. I always tell people, first of all, just try to address the fact that that's our own problem and not that person's problem. We should try to respect them by using that pronoun. But also sometimes what helped me early on was using their name. So instead of saying they, saying Katie, using my sister's name because she came here to support me. And then I think something that really is not necessarily part of transgender, but gets a little bit confused is people who are cross-dresser or drag queen. It used to be referred to as transvestite, although my understanding is that that's not really as common or accepted as of a term anymore. this is someone who might wear the clothing of a gender that differs from their sex, but they may not identify as that gender. It may just be something that they're doing socially or for entertainment purposes. And also, though, there are some transgender people that also do cross-dressing and drag. I like this animation, the genderbread person, not man, to explain, kind of the idea that there's this spectrum and that there's different parts of our gender identity, our sex, and our expression. And so identity is what's in your mind, and it can be anything from non-gender to a certain amount of womanness or maleness. Your gender expression is how your, outside appearance is going to be. Again, can be on a wide spectrum of things. You could maybe identify as really feminine in your head, but not yet feel really comfortable expressing yourself in that way. Biologic sex is generally determined by our genes, but as we'll talk a little bit about, intersex is also a condition that can be it's not always just straightforward like you're XX, so you're a female. And then who we're attracted to is, what's going on in our heart and how we're feeling toward people. But we can also have no attraction. And I think that's something we also have to respect in people. And then a little bit more about sex versus gender. So we talk about, gender reveal parties where when we get this ultrasound or we get like these chromosome tests and then we know the gender. One of my patient advocates made this in one of our presentations, so I thought was cute. It's a sex reveal party, right? And so we think we maybe know what that's going to align with in terms of their gender, but we're not always correct. And when our gender identity and our biology or sex align, that's considered cisgender. And when our gender identity and what our sex assigned at birth or our biology is doesn't align, then that's usually considered transgender. And then people talk a lot about pronouns. I actually, in seeing young children, try not to use the word pronoun because some young children don't necessarily know what that means. So I'll just say, I'm Dr. Dayton. I like to be called she. What do you like to be called? But pronouns are, she, he, whatever somebody prefers to be called. And it's a really simple way to validate someone's identity. It's also a very non-permanent thing. So when we talk about kids wanting to try out new names or new pronouns and things like that, I really encourage families, there's not a lot of harm in just letting them be called what they want to be called and seeing how it makes them feel. And it's respectful. When you use the wrong pronoun, it can make people, even though they may not outwardly express it, feel really terrible. And when you just call them by the pronoun they want to be called, you can really validate them and make them feel good. I think also a common thing is if you've used the wrong pronoun, what do you do? And I've been told by many of our patients, and what I usually practice is just saying, oh, I'm sorry, and then moving on, not really dwelling on it, because I think that also can be hurtful for them. But, identifying that you did make a mistake and then moving on. And then there's a medical term that you might hear a lot related to transgender care, which is called gender dysphoria. There are some people that wish that maybe this wasn't even a diagnosis or something that we had to talk and think about. I think it's a little challenging as the doctors taking care of these patients that we have to prescribe some medications. And whenever we prescribe medication, we have to associate it with a diagnosis of some sort. And so this is what we use right now. And I foresee this changing in the future to be less of a psychiatric diagnosis. But as it stands right now, gender dysphoria is a psychiatric diagnosis, which basically describes a transgender person, but not only a transgender person, someone who's experiencing distress or impairment related to their transgender identity. So it really doesn't fit every patient I see, but it's something that I'll have to use sometimes to be able to properly bill for their visit and provide them medication. And then when we talk about gender affirmation, this can be a variety of things. So gender transition isn't just medications, it's one step in transitioning and usually one of the later steps in transitioning. So a lot of times people will socially transition well before they'll start hormonal transition or surgical transition. And social, like I said, can be as simple as changing names and pronouns. I have some teens that probably have changed their name 4 or 5 times, just trying out different names. I actually had one really cute story that a teen, he was he couldn't figure out what he wanted to be called. And he finally said to his mom and dad, on my birthday, I want you guys to like tell me what you think my name should be. So on his like 14th birthday, his mom and dad gave him an envelope and he opened it up and he found out what his name was. And so he's like, you named me the first time. I want you to rename me. So that's not as common. Usually they don't want their parents involved, but I thought it was a cute story. And then, you know, also part of social transition is starting to get to the point they're comfortable enough to let peers, teachers know and be out in school. That can be really variable for people. That some people live in environments that's really comfortable and easy to do. And some people live in environments where that's a huge challenge. And we definitely don't like say to somebody, if you haven't done every single one of these environments, you can't then start hormones or something like that. But we just try to encourage people that we do know the more that you're able to be supported by your family and community, the better someone's mental health is going to be. And so we try to encourage them to be out as much as they can in order to feel more accepted and, you know, supported by those around them. And then legal transition can involve, you know, changing things like your birth certificate, your identity documents, and even up to changing like on their health insurance. So really everywhere they go, their name and pronoun will be correctly used. And finally, medical transition, which is where I come in, is when hormonal transition is used. I'll tell a little bit more about, and surgical transition. There are some terms that are really preferred not to be used. And I think it's important to know that too. Intersex isn't so much a term that we shouldn't use, but it's a term that's not really describing somebody who's transgender necessarily. Although an intersex person can also be transgender, which can be a little bit hard to wrap your head around. But someone who's intersex usually would be also a patient that I would see a lot of times, but for different reasons. So they might be born with genitalia that don't quite look male or female. They might have had some prenatal testing that told us that they had a certain type of chromosomes, but when they came out, they looked like the opposite sex. They may not develop puberty normally, and that may be because some genetic differences in their gonads, like in their testes and ovaries. And so those people are intersex, but they may still, you know, really even to be able to identify as transgender with that, you would have to say like, did we even really assign the right sex when we tried to figure out what this person's sex assignment should be? And that could be a whole ethical debate of should we even be deciding someone's sex, but we won't get too into that. It's a different area. Leave it at that. Transvestite, as I mentioned, is not as preferred of a term as like cross-dresser or drag. And then transsexual really it's a historical term that isn't used anymore and really was more specific to like a transgender person who had some sort of hormone treatment or surgery. Gender identity disorder was the old psych term for gender dysphoria. So we now use that. And sex change surgery is really not used anymore. Now it's considered gender reassignment surgery is the more appropriate term. I also like this cartoon. I have to credit Corey, our old patient advocate, for all the good cartoons. But I think there's like a big question in people's minds if kids can be transgender or not. And the idea is if a cisgender kid says that they are cisgender, we never ever question it. And they can know their gender identity from very young. But if a child is trans from a young age, we're just like, how could you possibly know? You're too young. How can you decide this? So it's a little bit, you know, a paradox. And then how common is this? Because I think you'll hear politicians saying that it's becoming really excessively common and that every kid is trans these days. And I mean, while it is a little blurry, but it is somewhat of a decent proportion of the US population. It's still about like 1 in 100 kids. It's not very common. It is becoming, I will acknowledge that this was from a 2022 survey. And when they had done the survey a few years back, the numbers were lower. And youth and the numbers in youth is like between 13 and 17 year olds in this survey so youth are 1.4%, adults are 0.5%. It is a much larger population. And like, you know, if you look over the years, like a 65 and up is like the lowest group. And then it kind of goes down over time. But I think that, you know, there's a lot of theories about like, why are there more youth that identify as trans now? And we think there's probably more visibility of this population these days. There's more acceptance. So people feel a little bit more okay with coming out to family and friends. But, you know, we don't really have like strong evidence to say exactly why. There is some theories on that you will read about what's called like social contagion, where people are saying they're becoming trans because they read about it online. And those theories have been disproven. I mean, there's been other studies that have looked at this after the first study came out and basically said this evidence was not reproducible, which is really important in science. If you're going to say like a theory, you need to be able to reproduce it in multiple different scenarios. And they have not been able to reproduce that social influence would cause someone to be transgender. I mean, honestly, logically in my brain, that's just insane. But we have to sometimes not just say that to people, but actually prove it with science. I'm going to talk a little bit about too what's going on in our state in a minute. But so why is it so important that we care about what's going on with transgender people, that we know how to take care of them? I mean, we know that there's a lot of discrimination toward transgender people, and really lately has been getting even more severe rather than better in some ways. This was a study from 2011 that showed that really high rates of, bias really throughout people's lives. So with jobs, with school, more physical assault and sexual assault in this population, and people not getting the needed health care. So yeah, that's going to lead to like poor health outcomes for them and even premature death. Again, the same survey showed in taking adults and youth, 41% had a lifetime suicide attempt. I'll tell you, it's even higher in trans youth. If you look at young trans males, up to 50% have attempted suicide at some point in their life. But, in the entire U.S. adult population, that's only 5 to 15% that have had a suicide attempt. So it's clearly a much higher risk from being transgender. There's also higher amounts of drug and alcohol use, which we, know that for many people is a coping mechanism because of this distress. And then many people are avoiding medical care, which, as I mentioned, can lead to a lot of more poor health outcomes for them. And what are their barriers? First of all, like not having enough qualified providers. We actually are very blessed to have multiple qualified providers in this room right now, but that's very unusual. Many times, even my own colleagues say, well, I wasn't trained in this, so I can't do it. You just go see Dr. Dayton. And really, there's very clear, easy to follow guidelines that most people should be able to do, but it's also just a lack of it's kind of a way to not be challenged to learn it too, I feel like. And then, definitely our patients, even if they have a qualified provider, need to get through multiple levels to see that provider. So they're going to have to go through the check-in staff and the nurse checking them in. And they might feel like even though their doctor is qualified, the people that are getting them to that room are not really treating them with respect. And if you're sitting in a waiting room and someone calls a name that you don't identify with any longer, you may not really want to get up and walk across that room and have everyone staring at you and wondering why that name was called when you don't look like that name. So there can be, a lot of like hurt with that, where people might not even want to seek healthcare. And then it also is becoming even more relevant that transgender is an excluded benefit. So trying to treat someone for gender dysphoria, as we call it, is something that now is excluded by Medicaid for both children and adults. So in our state, starting in August, that was passed that Medicaid would no longer cover any gender hormonal or surgical care. So that's happening. And then obviously for our youth population, it has to be supportive parents, because for us to treat youth for anything, parents have to be, except there's a few exceptions, but for almost anything, parents have to be involved to consent for treatment. Yes.
You said in Florida, Medicaid, the Florida Medicaid program. What about the federal Medicaid regulations?
So right now, so each state does their own Medicaid policy. The federal government is recommending that gender dysphoria be covered, but each state regulates their own Medicaid. So we are not the only state. There are, you can probably guess most of the states that have there. So I had a map that I didn't put in here, but it's like, there's a map of which states have explicit, like in their language, to say that gender dysphoria should be covered. And it's like California, New York. And then there's the states that have explicit that gender dysphoria will not be covered, which is a lot of the Southeast. And then there are many states that didn't have any language. And up until recently, Florida did not have any language that said whether it would be covered or not. And so it was covered for the most part, including surgeries. But now that this has explicitly been said that it's not going to be covered, the earliest impact I've seen is a lot of my patients' surgeries are being canceled. So even, 18 and up, not just young children, because we're not doing surgery on young children, but, adults are having their surgeries canceled, even though they were scheduled, 6 to 8 months ago. They're now not able to get surgery because of this change. And then soon people will be getting, not being able to get their hormones covered through insurance. I think that the people most impacted are going to be young children, because the medications we use for younger children, as I'll show you, those puberty blocking medications are the ones that are the most expensive. And all they are really is a pause on puberty. They're probably what most lawmakers would consider the least severe of what interventions we're doing, because there's no permanence to them. But because they cost many $1,000s per injection, people on Medicaid will never be able to afford these medications without some kind of help. Other medications we use, like testosterone and estrogen, have fairly reasonable out-of-pocket prices, so they probably will still be accessible to many people through using like GoodRx and coupons and things like that. Sorry to be a downer. All right, and then just a little bit more like about other barriers. But I think something really important to note, and I mentioned a lot of mental health disparities, but being transgender is not a mental health disorder, despite the fact there's a psychiatric diagnosis. The American Psychiatric Association itself has said that this is not a mental health disorder, that the reason that these people have higher levels of mental illness is because of their experience of discrimination leading to damaging their mental health. So, and we can say that pretty confidently because there have been studies looking at the differences in people who are transgender and have really good mental health and people who are transgender and have higher rates of depression, anxiety, suicidality. And it's the people who didn't have social supports. Those are the people that are at higher risk for those outcomes, which unfortunately is most of the transgender population. But there are, areas and families that have been really supportive, and those kids have much better outcomes. And then I did want to mention too, there's this type of therapy that's considered like reparative. It's been used for people who are gay, and it's been used for people who are transgender, and it is considered unethical. And it's actually banned. It's not banned, I don't think, in the entire state of Florida, but it is banned in our city for sure. What was that?
It's not even banned in
just the city of Gainesville. We've got to start somewhere. But some states have banned it in their entire state, but I don't think we're going there yet in Florida. I've kind of already mentioned this about mental health disparities. There are also higher rates of eating disorders and autism spectrum disorder. And there's some variable theories about why autism spectrum disorder tends to be a little bit higher rates in the transgender population. I think kind of the most compelling theory in my mind is that people who have autism sometimes have difficulty expressing themselves. And perhaps if you've grown up feeling like you were in the wrong body your whole life, it may have led to difficulty with self-expression through your whole life and a diagnosis of autism. Because many times it's not people with very severe autism, but more kind of like a milder end of the spectrum that are identifying as transgender as well. There's also kind of in my population too, I definitely see higher rates of discrimination in the school setting. We have a lot of patients who drop out of school due to pretty severe discrimination, and clearly that's going to set them up for less good, life outcomes if they can't finish school. And a lot of this has to do with feeling unsafe and experiencing discrimination. These are specific, like Florida level data about LGBT harassment, verbal, physical harassment, physical assault. So it's happening based on sexual orientation, gender expression, in pretty high rates, especially verbal harassment, and not only from other students, but from teachers as well. So what can help, right? So I'm telling you a million problems, but why? I think what we're trying to do and having a clinic and also doing things like this talk right now is to try to show you that if we support these patients in many different ways of their lives, we can help them be better. And medical transition is just a small part of that. But like I said, there's been studies to show normal levels of depression in socially transitioned trans youth compared to their peers. Parental support can show improved quality of life. When we do medications like puberty suppression, there's improved psych function. And actually, this slide was a little bit old because I think there's actually a lot more studies now in children showing the benefits of gender-affirming hormone treatment. We already had good data in adults, but it's always harder in medicine to get the studies done in children. We always have to do the studies in adults first and then follow with the studies in children. The treatments have also been used longer in adults, so it was easier to look at longer term outcomes. But now that we're having more data on children, we're similarly seeing improved psychologic outcomes, improved function. And some people will point to, well, not every study shows improvement. Sometimes they just show no significant change, but that's actually something, because we can't do controlled studies where we don't treat some patients because that's considered unethical. We have national and international guidelines saying that these treatments help. And so if I told some patients I was going to withhold treatment to try to see if they did worse than other people, that would not be ethical. So, the fact that we can show no change to some improvement is actually important. And I do want to bring up also, so why do I need to even tell you this? Our state Department of Health came out with a statement, I think in like June or July of this year, it came out where they said that we should not be supporting, as doctors, any of this. So even social transition all the way to medical transition for youth. So I'm regularly now practicing against what our state Department of Health says, and they say it's because it's experimental. But the slide was too full to show you all the references here, but I have many references to tell you why this is not experimental and why there have been many, many studies to say that this is the right thing to do. And national and international societies, pretty much across the board, all respected medical societies agree that it's not. So we're having a bit of a battle of what's real science right now.
That's for you.
Specifically for youth, that they, guidance from Department of Health is not law. So it's guidance. There was also guidance from a Department of Health that we shouldn't vaccinate children against COVID. And I would say most pediatricians have disagreed with that, including the American Academy of Pediatrics. So we've had some interesting guidance from our Department of Health, but it doesn't mean we can't do those things. Yeah.
The guidance from the Department of Health and the Medicaid already know we're not going to cover this. Does that open the door for like private insurance to say, well, no, we're not going to cover it either?
Yeah.
And could that happen at any time? Because it's also very hard to get like medical appointments.
Yeah. So
appointments made for my child that are months out. And since I've made those appointments, like the Medicaid, I'm like, yeah, no, we're not. Like, I feel like if the Department of Health is saying that and Medicaid is saying that, it's not going to be long before private insurances or other
follow suit. Yeah.
Like,
so I think just for the people on Zoom, like the question was, would private insurance follow suit basically on not covering? And I think that's definitely the risk, is that they can now. Now there's a standard that's been set. It doesn't mean they will always, thankfully. Like, these companies sometimes think for themselves and have a lot of LGBT employees and decide that they want to go outside of that, but it is a risk for sure. There is a glimmer of hope in that we have some really wonderful lawyers, some that work directly with me actually, that are working to try and reverse these decisions by saying they're unconstitutional, but it's not a quick process, unfortunately. The other real big threat is that there is our government right now is, our Board of Medicine right now is planning to vote on well, they haven't told us what yet, but on making some kind of rule about transgender care in our state. And when a Board of Medicine makes a rule, that's the governing body for our medical licenses. And so it's not going to be that it's illegal for people to get transgender care in our state, but it will be that as a doctor, if you do this, whatever they say is not right, then you could lose your medical license. So in a way, it's sort of like cutting it off by threatening the doctors to provide that care.
They're going to refile the law. Try to pass the law.
Yeah, our legislature has tried at least 2 or 3 times to pass laws on it, but has not, on specifically medical care bans, but they really haven't been able to get them off the ground so far. But it's probably just a matter of legislators individually not feeling they have enough support yet to make that move. But over time, that could change too. There's another question. I'm not a legal expert, but I feel like I'm having to become a little bit of one. All right. And so then I did want to talk a little bit about what actually do we do for medical care, so people can also just know the facts about that. So first of all, I don't do anything in a silo, especially as a pediatric provider. Every patient undergoes a pretty significant evaluation before they come to us. Also, we're a referral center, so people are coming from really all over the state, but specifically like North and Central Florida really has no other like main clinic they refer to. So we have mental health providers within our clinic, and we also we work pretty like around the state. We work a lot with mental health providers in people's local areas to help make sure that they're getting the supports they need, and also specifically assessments to make sure that there's no other conditions before, like no other conditions that might be clouding their judgment before they decide on things like hormonal therapy. We don't really feel like people need to prove that they're transgender, but make sure that any other mental health conditions they have are stable and well treated before they would start on hormonal therapy. So I'm not doing something without other people's input ever. And I will say that in adults, this isn't always a part of the care model. We consider adults more able to make these decisions. On the flip side, I think because of the high rates of mental health issues in this population, it's important for adults to also have access to mental health care pretty regularly. And then, so when we do decide with, along with the mental health provider, that hormonal therapy may be a part of this person's transition and may be helpful for them to feel like themselves more, we would usually start, depending on their age, either blocking puberty or starting hormonal treatment. Puberty blocking, at least in our clinic, is usually somewhere between 10 to 16 years old. And then the hormonal treatments, which usually we think of as testosterone and estrogen, are done at ages 16 and up. There is some, I will say with those ages, there's some allowance in the guidelines to have times that you might use hormones earlier. And those, again, are individualized decisions. As doctors, anytime we see a medical guideline, it's something it's like a starting point. And there are always allowances in any kind of medical guideline for times that you might go outside of those norms. So I think that's another risk just to point out with our Board of Medicine, maybe making a really wide statement about like, you can only use this at this age. We don't really have that for anything else we do as doctors. So it would be a really limiting thing. Well, that's true. Yes, there's a lot of parallels here. So the stages of medical transition, we think of it kind of as like reversible, partially reversible, irreversible. Everything as an endocrinologist that I'm going to do is going to fall into these first two categories. And surgeries we consider typically irreversible, although in theory, there are ways to reverse surgeries too. So the things that are reversible are the puberty blocking medications, period blockers, which is another name for like a type of birth control that we would use to block periods. And then hormones are the things that there's going to be some effects that are reversible and some that are irreversible from the testosterone and estrogen. Puberty blocking, just to really kind of give you a basic understanding, is a medication that we give typically as an injection or implantable rod that would not be started until someone has first shown a sign of puberty. So usually around 10 years old, a child will start to show the early signs of puberty. We know their body has started to have those signals that it's going to start changing. And when we've worked with the mental health providers and with the patients and their families, and we've all kind of agreed that this patient definitely does not want those changes to happen, we can give them a medication that would put a pause on that development. It would be, again, something that if you stopped it, the puberty would restart and their development would continue from their own body's hormones. So then we're going to give them this medication to give them just a little bit more time, basically. And I already said all of that. What are the risks of this medication? It's considered pretty low risk. So this medication we use in like 2-year-olds who start puberty. So we know that we've used it for many, many years in young children, and we've seen very little physical medication, and it does allow them to just have more time. That it was developed for young children with early puberty and is now used for transgender children as well. We do know that the longer that you don't have exposure to sex hormones in your body, those are important for our bone health. And so there can be some reduced bone strength. It should pick back up once they start on hormones or went off the blockers, which is pretty rare. But they won't necessarily have the same bone health that they would have if they had never blocked the hormones in their body. And then there's a lot of talk about, on the really extreme side, we're like castrating children chemically and these kind of things because we're giving them these hormones early. I would counter it to say that well before I ever start these medications, throughout the time that people are on these medications, we're having a lot of conversations about, do we want to preserve fertility? How can we do that? There's not a lot of options to preserve fertility options when kids, or preserve fertility when kids are really young, when they haven't gone through puberty. And so I'll talk with people before about, here's what the experimental things are out right now, ways you could potentially do it. We're good? Okay. Am I going over my time? Sorry. Okay, I'm getting close to the end. But yeah, thank you guys for coming. But I also talk to people before we make this step of moving on to hormones. Again, like you could come off these medications for a while, allow yourself to get to the point to preserve sperm or eggs, and then start the hormones. So we have lots of discussions about this. And then if people do decide not to do that, that's a decision they've made because that's what's right for them, not because they couldn't do it. And then the hormones we use, this is just kind of a basic list, but if people are wanting to be masculinized, they would use testosterone. Norethindrone is like a period blocking medication. And then if they were wanting to be feminized, they would use estrogen. Spironolactone is a medication we use to block testosterone. And then a lot of times people also use progesterone. The female body typically makes progesterone. People feel like it helps their mood and breast development. In terms of testosterone, what we know is that it will cause people's voice to be deeper. It'll cause facial hair growth and more muscle. The effect that no one wants is balding. And then it will have some changes to the genitalia. Specifically, people's clitoris grows when they take testosterone. And their fertility is reduced, but it's not gone. So we know for a fact that testosterone does not make you not be able to be fertile. There have been people on testosterone that have gotten pregnant. Which is not encouraged, but it has happened. But anyway, so it's not 100% that you're not fertile because you've taken testosterone. We know that for a fact. But the things that are permanent is when the voice is deeper, it's the thickening of the vocal cords that won't go away even if you stop the medication. If you grow facial hair, that type of hair doesn't really go away. Even if you stopped the medication, you'd have to laser or otherwise remove it. And unfortunately, balding is permanent. And is also a reason that I've had many patients decide after a few years to stop testosterone because it'll kind of stop wherever it was at. And so they may not have further balding if they don't take testosterone, but they may already have a deeper voice and facial hair. The risks of testosterone. So I think everyone also may think like these are super, super risky medications. And I really try to tell people that as we get more and more evidence, we're realizing that the risks are not as severe as what we thought in the past. And that a lot of times for testosterone, it's sort of like you're taking on your bodily risks of what you would have had if you were born male. So you have higher rates of cardiovascular disease, higher blood pressure, higher cholesterol, which also people born male tend to have a little bit higher than people born female. And then they have higher blood counts, which is specific to the testosterone medication. And at the most severe could lead to blood clotting, but is a really controllable thing because we can watch their blood counts. And then with estrogen, the main effects, what's really desired is breast growth. They have slower hair growth on their face and body and a more feminine body shape. Again, fertility effects are not 100%, so they might not be able to have children as well when they're on the medication, but they may be able to stop and have children. Thanks, Eric. The risks of estrogen, again, kind of taking on the risks of a female. You have a higher risk for blood clotting, as females tend to do. And the estrogen we use is actually a lower risk than like a birth control pill. And then they also higher risk of breast cancer because estrogen increases your risk of that, and some cholesterol effects with estrogen too. It's obviously aren't exhaustive lists, but kind of the biggest risks that we worry about. And then what about surgeries? Because everyone says we're doing surgeries on children. So I'll just say, as a really basic answer, surgery is done at 18 and up for the most part. We do have a handful of patients who have gotten surgery called top surgery earlier, which is like a breast reduction type surgery to have a more masculine chest. It's nothing that would sterilize a child or that would remove any reproductive part of them. That's really considered fairly unethical to do under age 18. And so we do not send patients for that or recommend that under the age of 18. And like, as the last few slides, I just want to give you guys some take-home points of how you can help these people. I mean, I think first of all, being informed like you are today is a huge help. And then, just treating people that you see and meet that are trans as people like you would anybody else, respecting them and however they want to be called and using their pronouns in really simple ways. I think you guys have a super welcoming environment. I mean, I come up and I see the LGBT flag right out there. So big win. And then knowing about our community resources. So this is just a small list. I'm sure I'm missing many things. I was at Pride Festival yesterday. So lots and lots of resources are available in our community, but being able to refer people to supportive places can also really help, including your church. So that's it. So if you have any questions, yeah. Oh, thank you.
Certifications and programs for physicians who are working with this, or
Yeah.
Are there fellowships involved, or is it strictly included in knowledge and fellowship?
So it is mostly people learning through their, exposure on their job, but there actually is, there's called the WPATH, World Professional Association for Transgender Health, has a course you can do that can be, it's like, you can go in person or do it online, several different modules. You can have a certain amount of supervised experience, and it can be for psych providers or doctors. There's 2 different courses. So there are certifications that are available. Yeah.